so glad that we continue to have good response for people who can't attend the sessions today, for example, but can go to our website, www.parkinsonCNO.ca, and look at the PDTV link and be able to access this at a later time. So you can do that. Also, don't forget that you can send questions to my CEO, Debbie Davis, and that's at DEBBIE.Davis, DAVIS, at Parkinson.ca. Or if you would prefer to give us a call at 416-227-3375, leaving me your name and your phone number. If you have a question, I will get back to you. Okay, so onward and upward. Today's topic, medications. So whose bright idea was it for me to try and tackle the topic of medications today? Mine, you say? Wow, I think I've bitten off more than I can chew this time. It's a little bit like when we get asked to do a presentation on Parkinson's in a hospital or in a nursing home or just anywhere, and then they give you 30 minutes to explain this very complex condition. Good luck with that. Okay, I'll stop complaining now and just get on with it. So, where to start? Before I talk about the various medications and how they work, there are a few things you need to know. First, just like everything else about Parkinson's disease, everyone is different. And this is particularly true when it comes to you and your medications. Sure, there are common threads. For example, everyone with Parkinson's who wants to control their symptoms will take Levodopa, either Sinemet or Prolopa, at some point in time. But when, how much, what effect it will have, whether or not it will have side effects, and what side effects might be, etc., 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 varies greatly from one individual to another. This holds true for all the anti-Parkinson's medications, which is why, while it's nice to know what other people are taking, and we know it's the first question that you ask each other when you meet, after you introduce yourselves, that is, and that is, what medications are you on? It's really important to understand that what works for Mary Smith may not be the least bit beneficial for you. Believe me, I've known many people over the years who have found themselves in hot water with their doctors when they go to their appointment and say, Jane Doe in my support group is taking blah blah, and she's able to move much better now, even much better than I am. Why haven't you prescribed that one for me? So the takeaway message here is trust your doctor to know what medications you need, how much you should be taking, when you should take them, based on his or her examination of you and what you are telling them about what is going on with you. You know, doctors are very smart people, but they are not mind readers. So it's very important that you communicate effectively with them in the short time you are with them. We have a patient summary sheet available to help you talk to your doctor, which lists all of the motor and non-motor symptoms of Parkinson's. And that will help you to start the conversation. If you would like a sheet, please call me at 416-227-3375, or again, write to Debbie Davis at the email address I provided at the beginning of this talk today. Ask for a summary to be sent to you. And don't forget, without the advantage of having any lab results or imaging, such as an MRI or a CT scan to guide them, it is very difficult for doctors to always know, what medication is best for you. Please cut them a bit of slack if they don't get it exactly right the first time. It is very much down to trial and error, a period of wait and see. Unnerving maybe, but it's the truth nonetheless. At the risk of sounding like a broken record, once again I urge you, if at all possible, to seek the expertise of a movement disorder specialist, a very special specialist who eats, lives, and breathes Parkinson's day in and day out. If you're not sure if you're going to a Parkinson's specialist, please call or write to us. We'll provide you with the list of some of these very knowledgeable doctors. Some have very long waiting lists, but we can direct you to one or two who can hopefully see you a bit sooner. It is also important to understand that the medications we currently have available are purely for symptom control. What I mean by this is that at the present time, there isn't a medication that will slow down, stop the progression, or reverse the disease process. So for those of you out there who are not taking any medication yet and are wondering when you should start taking them, the question you need to ask yourself is, how much are my symptoms interfering with what I want to or need to be able to do in my life? Please note I said need or want to do in your life. So I'm not just talking about your ability to be able to work. I'm also talking about your ability to play, have fun, enjoy your life. If your symptoms are preventing you from playing golf because you are very slow and you don't want to hold up other golfers on the golf course, or if you have stopped dancing, whether it's dancing with Parkinson's or ballroom dancing, things that you have enjoyed for years because you are too stiff and you can't move the way you'd like to, or if this is a lovely gardening season now, if you're not going out to the garden anymore because you're afraid once you get down you might not get up again, all of these things are about your quality of life. And only you can decide what that is for you. Again, your doctor can't read your mind. And if they don't live with you, which they don't, obviously, they don't know what is important for you to be able to do and what you can't do anymore and would like to do. Remember, they can't treat what they don't know about. If you're not taking medications because you're afraid of the side effects, or think that by not taking medications now that they will work better later on, think again. This is simply not true. Parkinson's progresses regardless of whether or not you take medication because, again, we don't have medications to slow down or stop the progression. So you're not doing yourself any favors by delaying starting medications, particularly if you can't do what you want to do. Also, if you're stiff and slow, you won't be able or even want to do exercise. And research has proven to us that exercise preserves mobility, as well as cognition, that's your ability to be able to think clearly, and it also enhances your mental health. So don't fool yourself by putting off the inevitable. Now for the $64 million question about what time you should take your pills. Again, no two people are alike, and there are many variables when it comes to the timing of medication. Read my lips. It is essential that you follow your doctor's orders as to the exact timing of your medication, as it needs to be tailored just for you. We often get questions like, my pill bottle says, take my pills 4 times a day. Does that mean I have to wake up during the night to take them? The timing of medication needs to be geared to you when you need them. So some things that you need to be able to report to your doctor are exactly why and when you need to be taking your medication. For example, things that need to be considered are, when do you wake up? When do you eat? What symptoms bother you the most? And what time does this happen? Do your symptoms waken you during the night? And also, what medications are the best for you? See what I mean? It's not a one medication fits all. That's for sure. Another factor to be considered is that levodopa, you may know it as Sinemet or Prolopa, is the most common medication for Parkinson's and is the gold standard. Something you may not know is that it gets metabolized in 4 hours. In other words, it loses its greatest benefit after 4 hours of time. So therefore, as a general rule of thumb, pills should not be taken more than 4 or 5 hours apart. Please note again, I said as a general rule. So again, I must stress the importance of having your doctor direct your treatment and the timing of your medications. This applies as well if you are experiencing wearing off. That's when the benefit of your medications is not lasting until the next dose. So your doctor needs to adjust the timing, increase the dose, or add other medications to your regime. Some people need a bedtime dose of pills, or one in the middle of the night if the symptoms are waking you up, or you can't get to the bathroom on time because you're too stiff or slow. But if your symptoms are not bothersome at night, then don't waste a dose because you're going to sleep through it anyway. Again, it's important that you understand the timing of your medication depends on you and when you need them to work for you. Another fact is that there is no such thing as taking too much levodopa. Again, everyone is different, and the benefit and side effects are very individual. Your body will tell you when enough is enough, or you will know when you have reached your upper limits, when the side effects outweigh the benefits. Again, at the risk of sounding like that broken record, I can't stress enough that increasing or decreasing your dose must be decided by your doctor. Another general point I want to emphasize is never stop your medications unless it is under the direction of your doctor. I will repeat, never stop your medications unless it is under the direction of your doctor. The brain is a very sensitive organ that doesn't take kindly to rapid changes. And you will find yourself with some very serious problems if you try, and that could result, I should say, in permanent damage if you try to stop your medication cold turkey. You will recall how slowly your medications were titrated into your system at the beginning. So the same precautions have to be taken if medications are to be reduced or discontinued for any reason. So if I don't get anything else across to you today, please hear this. Drugs are not a do-it-yourself project. Any changes must be decided in consultation with your doctor. It is helpful to understand what drugs you are taking, why those medications have been prescribed for you, and what side effects may result. You should be able to talk to your doctor and ask questions about the medications, and you also should be able to suggest changes that you feel might be helpful. But please, 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 do not change your drug regimen on your own. All medications for Parkinson's have one goal: to restore brain concentrations of dopamine to as near normal levels as possible. In order to achieve this, several medications, each with their own mechanisms of action, may be necessary in order to prolong your current level of function. Think of it like this. We routinely eat different foods each day to restore sugar levels in our body, such as fruit, sweets, and pasta. We need different medications to restore dopamine that has been lost over time. We talk a lot about dopamine and how the discovery was and still is referred to as a miracle. You will also hear it referred to as the gold standard. Everyone with Parkinson's will take Levodopa at some point on their journey. But just what is it? And why is it so important? Well, it's a neurotransmitter. But for those of you who are not conversant with doctor speak, that word doesn't explain very much. I know many of you are very knowledgeable, so this next bit might be a bit boring, but I'm going to give you the Sandy Jones version of the role of dopamine in the brain and how it translates to your ability to be able to move. We usually think of a transmitter as an apparatus or a piece of equipment used to send or transmit radio or television signals. In other words, a transmitter is a messenger. So we call dopamine a neurotransmitter because it is a chemical, a very specialized chemical, that is produced in nerve cells in the brain that permits the transmission of information or messages from one cell to another. Although Parkinson's disease affects the function of the muscles and may appear to be a disease of the muscles themselves are not the problem. The difficulty lies in the complex system that transfers or transmits the idea of a movement, which occurs in the brain, to the actual movement of the muscle in the body. Think of it this way. You have an electric kettle and you fill it with water. You plug the kettle into an electrical outlet on the wall. You turn the kettle on and you wait a few minutes. And guess what? The water starts to boil. But what if the kettle didn't have a cord that connected it to the electricity behind the wall? So you had no way of getting the electricity to the kettle. Would the water boil? Of course not. So think of your brain as the electric circuit board behind the wall outlet, your body as the kettle, and in this case, your muscles are the water. You need some kind of cord or a transmitter to get the messages to your muscles. That's what dopamine is. So your brain thinks of a movement, your muscles are responsible for the movement, and the dopamine is the message that connects these two things. So, without the electrical cord or the kettle to plug into the wall, the water won't boil. Just like without dopamine getting the message from the brain to the muscles, your muscles don't move. Very simplistic words, of course, to describe an extremely complex and complicated series of events, but at least it's a beginning. So, once again, what is dopamine, and why is it so important? So, dopamine is a chemical produced by the brain which assists in the effective transmission of chemical messages from one nerve cell to the next. It controls and regulates the action of movements, such as walking and balance, and responsible for smooth, spontaneous, and controlled muscle movement. So the loss of dopamine in the brains of people with Parkinson's is directly responsible for those symptoms we call TRAP: tremor, rigidity, akinesia or slowness of movement, and problems with posture and gait. The last point for this part of my talk today involves medication and meal times. We know that protein interferes in the absorption of the levodopa. And if protein and levodopa are in the stomach at the same time, levodopa may not be as well absorbed, which leads to a reduction in the control of your symptoms. Again, everyone is different, and some people don't notice this problem. Also, early in the disease process, people are not aware of any difference. Later on, when people begin to notice what we call motor fluctuations, that's when you have good or on periods when your medications are working well, and bad or off periods when medications don't appear to be working very well, people begin to notice that having protein at the same time as the medication does affect symptom control. Some specialists advise their patients to take their medications 1/2 hour before meals or 2 hours after a meal to try to reduce the interaction between levodopa and protein. It is important, however, to not be completely obsessed with this regime. Nothing dreadful is going to happen if you take your pill with food once in a while. Please check with your doctor before you change your medication and meal regime. So since many of the motor symptoms of Parkinson's are the result of a lack of dopamine in the brain, it stands to reason that most drugs used to treat Parkinson's are aimed at temporarily replenishing or imitating dopamine by increasing the amount of dopamine in the brain, stimulating the parts of the brain where dopamine works, or by blocking the action of enzymes that break down dopamine. I'm going to spend a few minutes of the talk today going briefly over the most common medications that are used today. As everyone with Parkinson's is different, again, there is no one drug that is suitable for everyone. So if you have any questions about your medications and why they are being prescribed for you, please consult with your doctor and ask again what side effects you might expect to happen. So the medications used for Parkinson's. I will start again with the gold standard. That's levodopa. And you might be taking levodopa, which is levodopa benserazide or Prolopa, or levodopa carbidopa, which is Sinemet. Keep in mind, many of the motor symptoms are the result of the lack of dopamine. And so again, most medications, including levodopa, are aimed at temporarily replenishing or imitating dopamine. Dopamine, or levodopa, is actually converted into dopamine in the brain and stored in nerve cells to replace depleted dopamine. It is indeed the only medication that actually is converted into dopamine. So if you combine it with another drug, such as carbidopa or benserazide, it allows more levodopa to get to the brain and reduces side effects, for example, like nausea. That's the job of carbidopa and benserazide. Again, it allows the levodopa, or dopamine, to get into the brain and reduces side effects. Levodopa also improves muscle rigidity and movement. Side effects of levodopa include involuntary movements. That's when you can't sit still, no matter how hard you try. The medical term for that is dyskinesia. Over the years of use, levodopa may also be associated with what we call wearing off. That's when your medications don't last or get you through to the next dose the way they did at the beginning. Another classification of medications are called dopamine agonists. They are, the most common ones are pramipexole or Mirapex, and ropinirole and Requip. There is another fairly new medication, which is a dopamine agonist, available today, and that's called Nupro or rotigotine. That is a patch, and I will be talking a bit more about that a little later on. So the job of the dopamine agonists are to mimic or imitate the action of dopamine in the brain. In other words, they fool the dopamine, they fool the brain into thinking that it's actually getting more dopamine than it is. These medications, the dopamine agonists, can also be used as an initial treatment or along with levodopa when people are in more advanced stages of Parkinson's. So again, dopamine agonists can be used at the beginning or toward the end along with levodopa. Side effects of the dopamine agonists can include sleepiness, hallucinations, that's when you see things that aren't really there, leg swelling, and sometimes what we call impulse control disorders. That's when you have obsessions with food, activities such as shopping, gambling, even internet use, as well as inappropriate sexual libido or inappropriate sexual use. Another classification is called Amantadine. Amantadine enhances dopamine release and blocks glutamate. That's another brain transmitter. It's often used to treat early symptoms and can be particularly helpful for people who have severe tremor at the beginning. Amantadine can also be used to decrease those involuntary movements I referred to a while ago as dyskinesias, and they can also improve the amount of dopamine that your brain is getting between doses. So therefore, they improve wearing off. So again, what I'm trying to get across to you today is that while dopamine remains the gold standard of Parkinson's medication because it actually enhances and turns into dopamine in the brain, all the other medications that I'm referring to today, the dopamine agonists, the amantadine, and the other medications I'm going to refer to now, are basically helpers. They help the dopamine to be the best it can be. Another classification are called COMT inhibitors. You don't need to know all the fancy medical terms about this, but if you're taking a medication called entacapone or Comtan, you might be interested to know that its job is to block a key enzyme in the brain that's responsible for breaking down levodopa before it reaches the brain. Therefore, it can improve the duration of the response that you get from your levodopa. Again, a side effect is the problem with dyskinesias with this medication as well. That's the involuntary movement. Stalevo is a medication that's actually a combination of levodopa, carbidopa, and entacapone. So it's a combination of Sinemet and Comtan. It substitutes individually administered immediate release levodopa and entacapone. In other words, if you're taking two medications, so that would be your Sinemet plus Comtan, you could replace that with taking one pill if your doctor agrees. And again, it's used to replace the levodopa, carbidopa, and when patients get benefit usually from this medication, experiencing end of dose wearing off. There's another new medication on the market today. It again has to be very carefully prioritized for patients. It's called Duodopa. We have been having some education sessions on the use of Duodopa, and that is levodopa carbidopa, so it's the Cinemat, but it's in a gel form, and it is administered throughout the day with a pump directly into the small intestine. It is used for people in advanced stages of Parkinson's disease, particularly those who have difficulty swallowing or who have extreme fluctuations when they're on for very short periods of time during the day. So again, this is something that you could ask your doctor about, and I'd be happy to send you some information about Duodopa as well. So there are other medications that enhance the effect of your dopamine by preventing it being broken down. Those medications are known as Mao Inhibitors, and they are things like Aldipril and Azilect. Again, side effects might be dyskinesia. A couple of medications that are not used very much anymore, called Cogentin and Artane, were used right at the beginning when we had nothing else to offer people with Parkinson's. And again, it helps to correct an imbalance in the brain. But it can cause increased confusion and increased problems with thinking, so it is not used routinely anymore. Sometimes, however, I have known it to be used very successfully for severe and uncontrolled tremor. So to summarize briefly what I've just talked about, we know that movement problems associated with Parkinson's are as a result of a decrease in the amount of dopamine in the brains of people with Parkinson's. Dopamine is the chemical message supposed to connect the thought of movement in the brain to muscles that carry out the movement. Not enough dopamine results in jerky, uncoordinated movements, as well as the inability to be able to move spontaneously, how, when, and where you want to go. The goal of medication therapy, therefore, is to replenish the lost dopamine, imitate the action of dopamine to increase or improve the effect of dopamine by acting as bodyguards to block the various proteins that are trying to break down levodopa before it even reaches the brain. In previous talks, I've focused on several of the non-motor symptoms of Parkinson's, such as depression, anxiety, swallowing difficulties, constipation, cognitive impairment, and all of these can sometimes be improved with the use of the medications I've talked about today. However, again, because everyone is different, the various medications that help you to move may not improve the non-motor symptoms, and in some cases may even make them worse. So once again, let your doctor know what is going on, as those other issues often respond well to specific and targeted treatments over and above the medications I've mentioned today. If you would like a copy of our brochure, What You Need to Know About Medications, please call 416-227-3375, or if you're long distance, 1-800-565-3000, extension 3375, or write to Debbie Davis, and it will be yours for the asking. So for those of you who haven't given up on me yet today and are still on the line, before I start the question and answer, there are just a couple more things I want to say about medication. Iron interferes with the absorption of levodopa, but if you need to take iron for other conditions you may have, the best medication to take is called Proferrin. That is called Proferrin. and it's best to be taken in the form of 11 milligrams and spaced out over the several hours, 2 or 3 times a day. Also, you need to know that crushing regular Cinemet, that's not Cinemet controlled release Cinemet, but regular Cinemet, and putting it in a bit of applesauce or taking it with a carbonated drink will speed up the onset of the absorption of the medication. But having said that, that means that it will wear off faster. So you need to keep that in mind, that you may increase the fluctuations more if you do crush your medication. It is very important also to give the anti-Parkinson's medications a chance to work. Don't just take them for a few days, not be willing to put up with the side effects, decide that they're not helping, and stop taking them. It can take 4 to 6 weeks before you feel very much benefit from your medications. They are given very slowly, as you know, and therefore they take a long time to get up to a therapeutic dose in your bloodstream. If you have severe side effects, again, please talk to your doctor, as there are things that you can take to calm those side effects down. So one of the questions I've had for today's talk is, are there interactions between anti-Parkinson's medications and common over-the-counter medications, such as analgesics, or those are known as painkillers, cold remedies, anti-inflammatory medications, or prescription medications, such as antibiotics, sleeping pills, antidepressants, or medications given for anxiety. The drugs used to treat Parkinson's disease are actually remarkably free of drug interactions with other medications. People taking Cinemet or Cinemet CR, that's the controlled release form of Cinemet, or dopamine agonists such as Mirapex, Requip, the rotigotine patch, etc. All of these medications that I have mentioned in my talk previously today are actually play very nicely with your anti-Parkinson's medications. Also, you can take Tylenol, aspirin, or any other anti-inflammatory drugs such as ibuprofen or Advil without fear of interaction. Antibiotics, when necessary to treat infectious process, can also be taken without interfering with the anti-Parkinson's medications. Although keep in mind, infections in and of themselves do interfere with the way your medications are metabolized. So keep in mind that most over-the-counter medications and even many prescription medications are very safe to take. But please, again, do talk to your doctor if you're considering taking any of those things, just in case there is some other reason why it might not be in your best interest to do so. Another question I've had is, how important is it for me to take my medication at specific times? It is very important to take your medications at specific times, and this is for a few reasons. First, your body needs a chance to get used to the medication, so having a routine rather than erratic dosing is much easier for your body to handle. Following a medication schedule is very important, as it also helps your physician to manage your symptoms so that he or she can keep track of when you are on or off, i.e., when your medications are working and when they are not. If you take your medications sporadically, it does not allow your doctor to fine-tune the timing and dosage necessary to help you control your symptoms. The importance of staying on schedule increases as the Parkinson's symptoms progress. In the early stages, the symptoms are more forgiving, and medication can be taken early or late without sacrificing control of the symptoms. But I think it is better to start as you mean to carry on. In other words, if you stay on a schedule right from the get-go, it will become a habit and will be ingrained in you for the future when you really will need to be regimented on a very regular basis. Another question, is it true that levodopa only works for a limited period of time? The answer is absolutely no. Levodopa is the most potent medication to treat Parkinson's disease symptoms and remains effective throughout the course of the condition, despite prolonged use. However, you know with these things there is always however. After several years, as symptoms become more severe, they can no longer be fully relieved throughout the day. So some people think that their medication simply isn't working anymore. Think of it this way. If you have a moderate headache and you take a Tylenol, the headache will disappear. But if you have a severe headache, the Tylenol actually only dulls the pain. It's not that the pain medication doesn't work. The pain is too severe to be controlled. The same with Parkinson's. Again, it's not that the medication doesn't work as time goes on. It's just that the Parkinson's progresses, you've lost more of your naturally produced dopamine over time, and it continues to be more difficult over time for levodopa to control all of your symptoms. But again, levodopa remains symptom effective throughout the course of the condition, regardless of how long you have been taking it. Another question I've had is, does Parkinson's medication cause difficulties with sexual performance? This gentleman has written and said, since I started medication for Parkinson's, I have had sexual problems, such as achieving an orgasm. It takes a very long time, and sometimes I lose my erection. I've had no problems in these areas before I started my medication. My medications have been adjusted, but there is no progress so far. I would like to thank this gentleman for asking and sharing this very important concern, as that I know it's a very common concern for people living with Parkinson's, and some people are very reticent or ashamed to ask their doctors about it. I am planning in the future to do a talk on intimacy and Parkinson's, and so it's a very important question. The short answer to this question is, I have checked with several experts in this field, and the consensus is that Parkinson's medications do not have a detrimental effect on sexual function. However, there are several other possible causes for these problems. And because I think that the continuation of a healthy sexual relationship is especially important to a person who has any kind of a chronic condition, I will go into more details in the session, my lunchtime chat about intimacy. But if the individual who sent me this question would like to speak to me sooner than this, again, please call me at 416-227-3375. I do think it's a very important question, and I would like to discuss these issues with this gentleman. Okay, so my colleague John Collins, who is helping me to ensure that this session gets broadcast to you today, has just said that he has some questions for me as well. So John, give me a second to finish the questions that I had previous to this today, and then I'll get to your questions. Okay? Fair enough. Okay. So, onward and upward. So as I said, the talk about the sexual difficulties will be addressed at a later time. I've had a call from another person, and I told you I was going to talk a little bit more about the patch. So the patch is called rotigotine, or Neupro, Neupro. And this person, I've had a couple of questions about this actually. So the first thing that is important to understand, the patch is not dopamine. It falls again into the category of a dopamine agonist, which mimics the action of dopamine in the brain and therefore makes the brain think that it's actually getting more dopamine than it is. So the criteria for the patch really is a matter of you're discussing this with your doctor. It is an expensive medication. It is currently not covered under the Ontario Health Benefits, but can be provided through some private insurers, and also can be accessible for people with Parkinson's under special compensation from your physician. So again, if your doctor feels that this is something that would benefit you, there are ways of having it covered. So as far as being efficient is concerned, the bottom line is that it's a patch. In other words, it's applied to the skin. The idea is that it smooths out the effectiveness of your medication throughout the day. And I have had several people anecdotally tell me that they find that it is quite beneficial. The jury is still out with some doctors, partly because of the cost, but partly because they're not convinced that it's any more effective, say, for example, than the other agonists such as Mirapex or Requip. So again, it's not a one-size-fits-all. So it's an important question to discuss with your doctor in terms of would it be more beneficial for you or not. And again, the cost needs to be taken into consideration. So I hope that answers that question. Again, another question about the patch, as feedback about its effectiveness. I think I've just answered that. Another question I've had is that there seems to be a lot of discussion about Parkinson's patients losing weight. Nutrition is going to be one of my talks in the future as well. This person's problem, however, pertains to gaining weight. Initially, she said that she lost weight, but then she said she got stuck for about a year, and now she's gained back 10 pounds, even though she's following the same food plan. So again, nutrition and Parkinson's, there is not very much information on weight gain, although I have also anecdotally met a lot of people with Parkinson's who have found that their medication causes them to gain weight. So there are some medications that can possibly result in weight gain. That might be the problem here. Also, that when this caller says that she got stuck for about a year, I'm wondering if that means that she was more sedentary. In other words, that she wasn't able to move very effectively. And we all know that when we don't move or exercise, that we can gain weight. So that may be another issue. But I think that quite often having a consultation with a dietitian can be very, very important with respect to medications and weight loss and or weight gain. but I will be dealing certainly with some nutrition aspects in a future talk. Now, John, you had some questions for me.
I do
Okay.
indeed.
All right.
I'm going to pause briefly just
Okay.
before I ask them.
Okay.
Thank you, Sandy, and thanks everyone for your patience. Now, some of these questions, Sandy, they came in during the presentation,
Yeah.
so you may have addressed them
Okay.
either now or previously.
Okay.
But I'll just ask them. The first
Sure.
is, what causes dopamine agonists to lose their effectiveness over time, and why is it not better to delay starting treatment with those?
Okay. Okay, so I guess I think I've addressed that to some extent. I think that, again, just like any medication for Parkinson's, it's the Parkinson's progression that causes people to feel that their medications are not as helpful as they were at the beginning. We often refer to medication at the beginning. People refer to it, and so do doctors refer to it, as the honeymoon period. And we all know that what that means is that at the beginning, symptoms are relieved very well. People get a great deal of benefit out of the medications at the beginning. But over time, as Parkinson's progresses, because of the continual loss of the dopamine-producing nerve cells in the brain, the medication continues to have a hard time keeping up with that cell loss. So it appears as though the medication is less effective. That's not the case. It's the Parkinson's progression that's causing it to feel like that. The other part of that question, John, was?
Why is it not better to delay starting them? Well,
Okay.
Why start them right away?
Okay. So again, I think I addressed the importance of the possibility, at least, of starting Parkinson's medications. Again, it's a discussion that you need to have with your doctor, but because we don't have anything to delay the progression of Parkinson's, I don't believe that you're really doing yourselves a favor by delaying to start to take the medication that indeed will increase your ability to be able to move, as well as other things that will be very beneficial for you. Okay, another question?
That's great. Along a similar vein, if someone hasn't yet begun medication,
Yeah.
when they do start,
Yes.
is there an expectation that you can share about the impact that will have?
Okay. So I guess, again, this speaks to the individuality of people with Parkinson's and the benefit that they could experience. Most people, in fact, I would say all people with Parkinson's disease experience benefit right from the beginning, as far as, well, when I say right from the beginning, sometimes it can take 4 to 6 weeks. Again, I caution you to think that, don't think that starting medication today will be, that you'll get an immediate benefit tomorrow. It can take time to get into the bloodstream, and again, it's given very slowly over time because the brain is such a sensitive organ. But the bottom line is that people, if you actually have Parkinson's disease, you will definitely benefit because, again, you're getting the very medication that you don't have enough of the chemical in your brain to help with smooth, controlled, spontaneous muscle movements. So it's a little bit like putting gas in the tank of your car. If you don't have enough gas in the tank, your car won't go. But if you put gas in the tank, then you will go. And again, I have met hundreds of people with Parkinson's who tell me that it's like a wow effect. And many people have said to me, why didn't somebody tell me how beneficial the medications are going to be, or were going to be at the beginning? If I'd known 2 or 3 years ago when I was putting off taking medication, what a wonderful benefit I was going to have. I would have started it a long time ago. So again, it's something you have to be ready for. You have to feel the positive about it as well, because again, your attitude can affect how effective the medication will be.
Thank you. A specific question about those taking levodopa carbidopa combination. Can you comment on two specific issues, excessive sleepiness and dry mouth?
Okay.
And perhaps how they relate to the medication or any coping strategies?
Right. Okay. So one of the side effects pretty much of all of the Parkinson's medications, again, for some people, not everybody experiences this, but can be excessive sleepiness. They have a sedating effect on many people, especially at the beginning. So again, this is something that that your system will get used to. You will be able to build a tolerance for the medications. And again, is it just the side effect of the medication that's causing the sleepiness, or is it also the fact that your Parkinson's, because your muscles are playing against each other, not playing nicely together, are also causing you to be fatigued and sleepy? The sleepiness, as I said, usually wears off after time, but again, if it continues, again, you could ask your doctor about that as well and see if something could be done in terms of maybe reducing the dose if that's necessary, or maybe it's just something that you need to give your body the opportunity to rest when you feel that sleepy. The side effect of the dry mouth is very, very common. Again, there are things on the market. There's one particular product that a lot of people benefit from. It's called Biotene, Biotene. There are different forms of this product on the market, and often that can help reduce the effects of dry mouth. But again, that's very common. So unfortunately, there are not sort of magical answers for that. But again, it's something I think that is important, that even if you have to carry a water bottle with you all the time, which a lot of people with Parkinson's do, because their mouths do get very dry. But I think the benefit of the medication for most people outweighs the side effect of dry mouth. And again, try the Biotene product and continue to drink more. And something else to produce more saliva is chewing gum, because again, I think you would recognize that, or if you put some kind of like a hard candy in your mouth, it automatically causes you to salivate. So those things can increase the saliva production, so you have less of a dry mouth. We're going to have to stop very soon. Is there another question?
So I have two more,
okay.
And we are running short on time.
Okay,
so I'll pose them to you quickly. Is that fair?
That's okay. But we're going to be at the hour time. Maybe can you send those to me, John, in the email, or can?
I am most happy to, and I do know whom they've come from.
Okay, great. So John has a couple more questions. So for those of you, because this was a kind of long, drawn-out talk today, who haven't had your questions answered, John's going to give them to me, and I'll respond to you via email. So I just want to say two things very quickly. I meant to explain when I was talking about levodopa, carbidopa, or Prolopa, levodopa benserazide. The 100 that you see on the pill bottle, the 100 is the amount of dopamine in that pill. So it's 100 milligrams of dopamine and 25 milligrams of carbidopa or benserazide. So again, people wonder what those numbers mean, and that's what it means. So you're getting 100 milligrams of dopamine, 25 milligrams of carbidopa. Also, Cinemet, controlled release Cinemet, is not as predictable as levodopa, carbidopa, without being a controlled release. So it's less reliably absorbed, and the slower release is not always helpful. So again, if those of you who are on Cinemet CR and are finding that you're not getting the same bang for your buck, you might want to ask your doctor if that's important. The next session, just so you know, is going to be on hospitalization, what you need to know when going to hospital with Parkinson's. And my last thought for today is that one of the most helpful and hopeful arms of research is looking for a medication that will slow down or stop the progression of Parkinson's. If I asked you to reflect back when you were newly diagnosed and the doctor said, you have Parkinson's and here is a medication that will prevent you from getting any worse, I'm sure that you would feel much better. So the bottom line is, levodopa was the first miracle. It's time for a second one. And in my opinion, that will be what we call neuroprotection, the second miracle when it comes to the treatment of Parkinson's. Thanks so much for listening today. I appreciate your participation.